Hi, everybody. My name is Carolyn Bradley. I am a PhD student at Palo Alto University in Northern California. And on this project, I work with Dr. Janice Haybarth. And the title of this poster presentation is Somatic Arousal as a Mediator Between Trait Mindfulness and Pain Catastrophizing. So chronic pain and in particular pain catastrophizing have many adverse outcomes related to mental health, physical health, and just overall poor quality of life. So how do we define pain catastrophizing? Pain catastrophizing is defined as a maladaptive way of coping, perceiving, and approaching one's pain experience. Usually this is rooted in things like helplessness, magnification, and rumination around one's pain experience. And so pain catastrophizing can lead to very poor mental health outcomes. We know from the research that those who are likely to catastrophize their pain are much more likely to have major and persistent depressive episodes. They're more likely to have higher suicidal ideation as well as even completed suicide. They're more likely to have substance use difficulties, particularly alcohol misuse as well as opioid misuse. And we know right now that's a particular that's a really large epidemic within the United States right now is opioid misuse. In addition, other mental health outcomes associated with pain catastrophizing include anxiety disorders, obsessive compulsive disorder. Pain catastrophizing is also comorbid with trauma, PTSD as well. Physical health outcomes. So those who are more likely to catastrophize their pain are much more likely to have, poorer recovery from either medical interventions. They're much more likely to have persistent pain, to not respond well to medical treatments. They are much more likely to have overall higher levels of ongoing physical disability, a more difficult time being mobile, walking, running, those kinds of things, and just overall poor quality of life. So in individuals who catastrophize their pain, they tend to socialize less, they tend to be more isolated, they tend to be more cut off from things that they used to love doing. So just overall poor quality of life. In addition, they tend to have lower levels of employment. It's hard for them to return to work, school, finish education. So catastrophizing pain can really have a very adverse influence upon one's life functioning. So the constructs within this study were trait mindfulness. So how do we define trait mindfulness? Trait mindfulness is a baseline level of one's mindfulness. So rather than an intervention or a treatment to increase mindfulness, this is more so someone's permeating baseline level of mindfulness, the way that they kind of, mindfully go about their day, so to speak. Trait mindfulness. So we use the FFMQ for this study. We use the 5-facet mindfulness questionnaire. 15. So the FFMQ uses different measures for trait mindfulness, such as observation, describing, acting with awareness, non-reactivity, and non-judgment to one's inner experience. So for this study, we use non-judgment because that mapped on statistically very well with our data. So why is trait mindfulness important for pain catastrophizing and somatic arousal? Trait mindfulness has been shown to be inversely associated with pain catastrophizing, where people higher in trait mindfulness tend to catastrophize their pain much less. People higher in mindfulness also tend to have and report lower levels of subjective somatic arousal. Okay, somatic arousal. For the purposes of the study, what is somatic arousal? So that's someone's subjective, for the purposes of this study, their subjective arousal, such as sweaty palms, heart rate, shaking, shortness of breath, stomach upset, tingling, muscle tension, those kinds of things. So somatic arousal actually is positively associated with pain catastrophizing, and again, negatively associated with mindfulness. So our study hypothesis was that somatic arousal would mediate that inverse relationship between non-judgment and pain catastrophizing. So methods. For our measures, we measured pain catastrophizing using the gold standard measurement for pain catastrophizing, which is the pain catastrophizing scale, or the PCS. For trait mindfulness, we use the brief version of the FFMQ, so the 5-facet mindfulness questionnaire 15. For subjective or somatic arousal, we use the physiological arousal questionnaire. And then for our covariate of the study, we were looking at substance use history. So we use the CAGE-AID, which encompasses not only alcohol use, but just overall general substance use history. Participants, we aim to collect around 200 participants. We ultimately collected 114. Responses, demographics collected. We collected a whole range of different demographic factors, such as race, ethnicity, age, sexual orientation, gender identity, sex at birth, region of which participants live, marital and family status, parent status, subjective and raw socioeconomic status at childhood. So all kinds of demographics were collected here. For our recruitment, we used an online Qualtrics survey. And so we utilized Amazon MTurk to recruit participants. Participants were able to participate if they met eligibility criteria, such as if they were between the ages of 18 and 83 years of age, if they were fluent in English, had chronic pain, and resided within the United States. So here's a picture of the statistical mediation model where physiological arousal is our mediating variable and substance use is our covariate. Mindfulness, meaning non-judgment, is our IB, and pain catastrophizing is our DV. So ultimately, the mediation analysis showed that our hypothesis was supported. There was a significant partial mediation. Although path A was non-significant, there was an indirect path, meaning path A multiplied by path B, that was significant. Also, there was a significant path between substance use and pain catastrophizing. So what does this look like? This is what the model looked like. So you can see the path between non-judgment and pain catastrophizing was significant, and the path between arousal and pain catastrophizing was significant. So discussion, what do these findings tell us? So they suggest that we should consider baseline levels of mindfulness, particularly non-judgment of inner experience and arousal when screening for pain catastrophizing and treating pain catastrophizing. We should also potentially use interventions to booster mindfulness and also decrease arousal. We should also always consider a patient's substance use history when screening for pain catastrophizing, and just working with chronic pain patients in general, considering there's such a high comorbidity between substance use and chronic pain in general. So here is a QR code that you can use with your phone to have access to this research paper. And I hope that you enjoyed this research poster and just have a great rest of your day. Thank you.